Good evening, everyone. This is Manish Mandlia. I am working as a CEO in Alveo Pharmaceuticals, and I welcome you all on this grand evening of webinar on COVID-19 and diabetic complications. Let me first welcome the eminent speaker today, and then I'll give you the introduction about everything else. Let me welcome Dr. Satyam Chakraborty. He is DM Endocrinology. He is consultant endocrinologist and diabetologist at Lotus Hospital, Kolkata. He is honorary faculty in reproductive endocrinology, Department of Physiology, University of Kolkata. He has got a lot of publications under his belt, and he has got 14 publications in index journals. He is presented at Endo 2019, New Orleans. He is also presented at EndoBridge 2014 at Turkey. He has been an eminent speaker in ESICON, Endocon, a lot of conferences across the world. Let me give you the brief about the objective of this webinar. COVID-19 in the last 1.5 years of havoc across the world. Second phase, and the third phase is on the way as per a lot of reports which are there. I'm sure today's session, Dr. Satyam Chakraborty will give us an in-depth understanding about COVID-19 and diabetic complications and how to treat those diabetic complications post-COVID-19. So without taking more time, I hand over the dais to Dr. Satyam Chakraborty. Over to you for the today's presentation.
Good evening, everybody. I'm thankful to Alveo Pharmaceuticals for giving me this opportunity to discuss one of the most important topics of today's health scenario. So, I go back to the initial days of the COVID-19, and I will request each and everybody to please keep yourself muted when we discuss it, so that it is easy for each and everybody to discuss among ourselves the various complications, the various associations which is pertinent to today's discussion. So I hope I am audible to everybody. Can anyone reply? Am I audible to each and everybody?
Yes, Dr. Saab, you are audible. You are audible.
So this was me when the pandemic started, and this was what I thought when the pandemic started. I was lucky enough that I am not a pulmonologist, internist, or an intensivist, and I won't probably have to deal with any of this dirty thing coming up called COVID-19. Man proposes, God disposes. After 2 days, an 82-year-old female diabetic for the last 25 years on oral hypoglycemic agent presented to our hospital emergency with drowsiness, 15 days, 8 days fever and dry cough and shortness of breath for 6 days, presented to the emergency at dawn. Neck veins were collapsed, chest bilateral crepitations, quite a low blood pressure. On admission, CVG was high. What the lab report, they called me at around 9:30 a.m. in the morning, and they told from the lab report was coming a blood glucose of 824. and the glucometer was showing only high. Urine ketones were stress temperature of 102 degree Fahrenheit. Denied travel history, and previous renal functions were within normal limits. The patient was admitted in isolation ICU. Now, this was the initial ABG on presentation, where we find that there was hypoxia, there was some alkalosis also, a bit of, and Dr. Guho is raising hand. Can we discuss? Dr. Guho, should we continue?
Abhishek, please unmute Dr. Bhua.
So let me continue. What we find was that there was quite a bit of dehydration. The sodiums were quite high. Now, this was the initial presentation of the patient. The osmolality parameters, which you can well see, the serum osmolality was 412, which was very high, HbA1c of 18.9, serum sodium 159, urea 229 with a creatine in 1.2. So you can
একটুখানি
understand
দেবে
the level of dehydration. একটুখানি কি দেব? Anybody? Someone wants to come in? When we are discussing, someone wants to come in? I just heard একটুখানি দেব. Huh? The organizers, please help me. Some of my colleagues want to come in over here.
Sir, some of your colleagues want to join.
I found somebody speaking. They want to ask me some questions.
No, no, sir. What we will do is you keep on doing your presentation, and then at the end we will take the questions. Otherwise, in
No,
model
someone
it will
wants
be
to
very
come in
difficult to
because I am
incorporate
hearing
everybody's in
voices.
blocking
I am
everybody.
hearing voices.
I'm just blocking everybody now. I'm just blocking everybody. I'm just blocking everybody now. Nobody can join now because the people join in between comes out. So we are blocking the entry of anybody now, and we
No,
are
no, I
continuing
am
with our
hearing some
presentations.
voices. They want
So
to
you can
speak
continue, sir.
something.
No, no.
Okay, so let's proceed. So this was the initial chest X-ray at presentation, and I hope you can well understand what it was. By now, everybody of us is well acquainted with this chest picture. Now, follow through. Immediately, we started fluid therapy with half normal saline. Insulin infusion was started with serum potassium monitoring 8 hourly, placed on broad spectrum antibiotics. Swab for COVID 19 was set. Now, the swab test, it came after 24 hours and asked for a repeat sample. So, time was going on, and we are just doing the fluid management, bringing down the Himalayan level blood glucose under control, and going here and there. And after again repeat sample was sent after 4 days, the report came beta corona positive, but novel COVID-19 is negative. This was the result of the report. So we were in a mess. What was it, whether it was actually a COVID-19 or not? So we reported the case to the ICMR, and where the ICMR instructed us to maintain strict isolation because most probably we were dealing with a COVID 19. Again, the sample was sent, and finally, we found that it was COVID 19 positive. So, it was around 6 days from the day of admission that true diagnosis came. So, it was a case of COVID 19 presenting with hyperosmolar non ketotic state with severe hyperglycemia. So that's another presentation. So back to the index case insulin infusion with fluid support maintaining a positive balance. 24 hours insulin requirement was 164 units on day 1, came down to 98 units on day 3. Second generation basal insulin was administered at night, overlap of around 8 hours. Infusion was stopped with basal and ultra short acting analog correctional regimen as the patient was on RT feed. Follow through gradually, the respiratory rate normalized in the next 4 days. Patient was shifted to a basal bolus regime with a ultra short acting analog after 7 days when she started taking orally. Shifted to general isolation on the 10th day of hospitalization. Requirement gradually decreased to as low as 24 units per day. After around 15 days of admission, patient developed psychotic features and had variable food intake. Now, it was not only because of the isolation but also for the steroid, which was. I hear some voices again. I hear some voices. Anyone wants to come in? Any doubts? Huh? Okay. After around 15 days, patient developed psychotic features and had variable food intake. Had 2 episodes of hypoglycemia, even with minimal insulin dosing, so insulin was finally stopped. Patient was finally discharged with first generation basal insulin, 8 units with linagliptin. 14 days post discharge, there was absence of any residual psychosis. Feeding improved. There was an increase in blood glucose levels. Regimen changed to biphasic aspart twice daily with sitagliptin and metformin. And this was the blood glucose charting when the patient presented to us after around 3 weeks. At 3 months follow-up treatment, patient has a satisfactory glycemic control of HbA1c of 7.3, creatinine 1.1. And this was the final chest X-ray of the patient when the patient was after 3 months. So this chest X-ray was quite clear without any residual fibrotic features, which was quite evident in many patients of COVID. And this was one of the initial cases which was published where 82 years female survived COVID-19 who presented with hyperosmolar non-ketotic state in our hospital. So, welcome to our today's discussion, diabetes and COVID-19. And we know that there is a strong relationship between diabetes, infection, and finally, when it comes to COVID-19, the risk of infection is higher in individuals with diabetes, maybe any infection. People with diabetes are recommended. That's why vaccination not only associated with an increased risk, but it is also associated with increased severity of infectious disease. Presently, there are limited data about COVID 19 in patients with diabetes. COVID 19 is more severe in patients. These are the facts which we have till date, and these are the data which suggest the same. And what we find that the severity of COVID 19 when diabetes is present as a COVID comorbidity is much higher. And that is the point that when uncontrolled diabetes is there, the COVID 19 becoming much more severe is increased. So these are the other studies which support the same, where we find the percentage of diabetic patients among survivors and non-survivors, and we find that the non-survivors patient who had diabetes, diagnosed or undiagnosed, were much high, and this was another evidence. And what we find that the case fatality rate in patients who have diabetes is much higher than the general population. So here we come to the pertinent point that it's important that people with diabetes. Someone wants to come in. I presume it's a quite poorly organized. People with diabetes maintain a good glycemic control as it might help in reducing the risk of infection and also the severity. Patients with diabetes and coexisting heart disease or kidney disease need special care and attempts should be made to stabilize their cardiac and renal status. Attention to nutrition and adequate protein intake is important. Deficiencies should be corrected. What is the ADA guidelines? People with diabetes are not more likely to get COVID-19 than the general. The problem is people with diabetes face is primarily problem of worse outcomes, not greater chance of contracting the virus. So this is the main point over here. So people with diabetes do face higher chance of experiencing severe complications of COVID-19. Patients with diabetes are more likely to experience severe symptoms. If diabetes is well managed, that's the important. The risk of getting severely sick from COVID is about the same as the general population. So when people with diabetes do not manage their diabetes well and experience fluctuating blood sugars, they are generally at risk for a number of diabetes related complications, and COVID-19, if strikes at that point, may become severe. So these were other studies where blood glucose levels in elderly with type 2 during COVID-19 outbreak, and what we found that there were certain problems in normal patients, that is there due because of the lockdown, and we found that there was a limitation in the level of physical activities. There was an alteration in dietary habits, particularly in patients who are regular office goers. Once they started having sitting at home, they there was a tendency to binge, and procurement of anti-diabetic medications and glucose strips were far more difficult at that time, and loss of the fine tuning by regular visits to physicians were also hampered. I will express my gratitude to certain pharmaceutical companies who tried their level best to keep the supplies of the medicines at per se. But I would also say that there were certain pharmaceutical companies who did great amount of injustice to the patients during the lockdown, and we condemn those type of acts by pharmaceutical industries. So the patient, on the other hand, the diabetic subjects, they were boozed with diabetic distress on one hand, COVID distress on the other hand, and economic distress. So these were the distress in which the patients were on. So it was testing times for us. We are gradually tiding over it. We have to understand few things about it, and the way out during this lockdown eras may be work on isolated, practice at home several aerobic exercises. Maybe the walker is the best time not to be the wardrobe, and you can also practice your aerobics in the balcony. And household chores that aid weight loss are always entertained. Having a nutritious diet is one of the most important things. So these are the practical recommendations for the management of diabetes. Sensitization of the patients with diabetes for the importance of optimal metabolic control. Optimization of current therapy is appropriate. Caution with premature discontinuation of established therapy. So these are the points where we should be careful. Coming to the interfering agents, if I come one to one, metformin, if a patient who is having COVID is on metformin, and if it is non severe COVID and the patient is asymptomatic, there is no problem in continuing metformin. However, we should practice caution if the patient is in a state of severely diseased COVID with and is admitted in the ICU. It is better to hold the metformin and only use the insulin for controlling the blood glucose. Now, SGLT2 inhibitors, again, SGLT2 inhibitors can always be continued in patients who are non-serious COVID. But once the patient has fever, and the patient, there is a chance of the patient getting dehydrated, it is better to hold the SGLT2 inhibitors and skip to other agents for the glycemic control, and reintroduce SGLT2 inhibitors when the patient is afebrile. Again, GLP-1, these can always be used, and these have proved to be wondrous. But if the patient is already losing appetite, and continuing GLP-1 receptor agonist may further aggravate the scenario. That's why we have, if at all we are using it, we have to use it with caution. But in our institute, we have used this wonderful agents in few cases where the insulin requirement in the ventilated patients also, where the insulin requirements were huge, going up to 250 to 300 units per day, and the patients were overtly obese. The patients were obese, and patients were on ventilator. To bring down the insulin requirement, we had to use GLP-1, and none of our patients had any adverse outcomes. Rather, the insulin requirement decreased in these patients. DPP4 inhibitors, again, these are more or less generally well tolerated and can be continued. Insulin is the mainstay of therapy during the COVID 19 patients, in the COVID patients who are in the hospital, not only in the critical care state but also in the non critical care state. The basal bolus regimen is the mainstay of therapy, particularly if the patient is on corticosteroids. The basal bolus regimen is the most beneficial, with second generation basal insulins and ultra short acting analogs. So connection to the health models and telemedicine should be used to continue regular reviews and self-medicating educations. And while injecting insulin, this is one of the things which you should be careful, because this is my practical experience. What I found when I examined the sites of insulin injection, even in patients who are admitted, if you check the injection sites who are on long term insulin use, you will find one of them. And make take it from me, if you inject if the your nursing professionals inject insulin in these sites, the blood glycemic control is going to go more haywire in the COVID-19 disease patients, if the patients happen to be on corticosteroids. So please check the injection sites. So another practical experience while working as an endocrinologist in the COVID ICU, what we found that extremely fluctuating glycemic profile, because not only because of the disease state but also more so because of the corticosteroids being used time and often. Now, four patients presented with recurrent episodes of hypoglycemia with hyponatremia with normal thyroid function, two of them diabetic and the others non diabetic. These patients were not put on steroids. And what we found, that there was significant adrenal insufficiency in these patients. And when we searched the literature, we found that this is another secondary adrenal insufficiency is also common in COVID 19. Most of the patients, because they are put on steroids, this secondary adrenal insufficiency gets masked. But we should keep this point at the back of our head, because when the patient are weaned of steroids, most of the patients complain of profound weakness, and the reason might well be a underworking adrenal gland. So, in a nutshell, we have to understand that diabetics might not have increased chance of contracting COVID 19. Diabetes with uncontrolled hyperglycemia might have increased chances of having severe disease course. Non pharmacological interventions are of paramount importance at the juncture. Pharmacotherapy needs to be patient centric, and telemedicine might play a vital role. Awareness of endocrinological parameters in critically ill patients are extremely essential to decrease the morbidity and the mortality and the duration of hospital stay in patients of COVID 19. So it's time to move on. Thank you.
Okay, Dr. Saab, that was an interesting session from your side. The forum is open for the questions. If anyone has got questions, I request to write in the chat box and the Dr. Saab can take it and then answer it. That will be more homogeneous way of doing it. So anyone has got a questions across, please write in the chat box and get the answer from Dr. Saab.
So I think I think by now my
Dr. Sahab, am I
colleagues.
audible?
Yes, I don't find any questions. So most probably by now we are all apt in managing the cases of COVID-19 with diabetes.
Anyone has got questions, please write in the chat box.
Sir, good evening, sir. The question asked by Dr. Surendra Kumar. The question is therapy for COVID you suggest, sir.
Do you think this is the right podium to answer this question? I don't think so, because we are concentrating on the diabetes complications of COVID-19, and this is not my authority place of authority also, because I manage the glycemic complications of COVID-19. I think we work as a team, and my COVID-19 expert colleagues would have been much more authorized to answer this question. I don't have the authority to answer this question.
True, true, sir. You said the right thing. The question is not for this forum. Anybody has got some other question across, please?
So I find another question: if a patient who was a non-diabetic before contracting COVID, but after discharge she is having elevated blood glucose, is it a side effect of steroid administered? Very good question, and we have to keep in mind that whenever any patient comes to your hospital with COVID-19, gets admitted, a HbA1c is mandatory. This will solve the basic issue, whether it is a steroid induced hyperglycemia, or there was an underlying undiagnosed diabetes which practically caused the severe COVID, which resulted in the hospitalization. We are accumulating data, and we have found that particularly in the second wave, there were a lot of patients who have been admitted in COVID-19 who were not having diabetes per se, but HbA1c was high. So it was basically undiagnosed diabetes which caused the severity of COVID, and that's why the patient required hospitalization. So we are tabulating the data, and most probably it will be published in one of the journals shortly.
Anyone else has got a question, please? I think, sir, the questions are not there. So, as a closing remark, I would like to thank you for the wonderful presentation you have given on COVID-19 and the diabetic complications. I'm sure with your understanding and your case presentations, people would have been benefited, and we can have further more interactions in the coming days. From Dr. Neeraj Kumar from Bihar is saying, a nice session, sir. So we all have been benefited with your presentation, and I look forward for more talks from you in the coming days. Thank you, Dr. for the wonderful session to all of us. Thank you once more. Thank you, sir.